Hello, my name is Lisa Tyvenin. I'm the District Stroke Coordinator at Sioux Area Hospital. It is my pleasure to introduce Kassi Fritz to you today. Kassi is a very outdoorsy person who loves hiking, skiing, backpacking, and camping. She loves all things outdoors. Her outgoing personality has led her to a career as an occupational therapist. She is equally as passionate about acute care stroke rehabilitation. She promotes health and sets a great example to all who know her. Kassi is a 2018 graduate of McMaster University and is currently practicing at Sioux Area Hospital in Sault Ste. Marie, Ontario. She will be discussing cognitive and visual perceptual deficits after stroke. Welcome, Kassi.
Thank you, Lisa. As Lisa said, my name is Kassi Fritz, and I'm an occupational therapist currently working at Sioux Area Hospital in Sault Ste. Marie, Ontario. And today I'll be talking about cognitive and visual perceptual deficits after stroke, specifically related to patients admitted to hospital on acute care units. So here are the learning objectives for this presentation: to define cognition and visual perception, to learn how to identify cognitive and visual perceptual deficits post-stroke, to talk about the importance of initial screening for cognitive and visual perceptual deficits after stroke, to explain OT or occupational therapy in regards to cognitive and visual perceptual deficits, and to apply strategies to help patients with cognitive and visual perceptual deficits on acute care. Please note that ultimately I created this presentation to be very clinical and practical with tangible suggestions and strategies so that you can leave this talk and directly apply what you've learned during your next shift. So what is cognition? So first off, cognition is very complex. When I explain this to patients, families, and staff members at the hospital, I usually boil this down to memory and thinking, because cognition is not a simple word that many people understand. However, you could spend weeks talking just about the different types of cognition with whole textbooks just on cognitive rehabilitation. So here is a very simple summary of cognition, and please bear in mind that this is not extensive by any means. Attention is related to concentration. Orientation is awareness of time, place, person, city, building, floor, etc. Memory is composed of short-term, long-term, working memory, and other types of memory. Insight and judgment are related to awareness of limitations and capabilities. Sequencing of tasks and problem solving are also important areas of cognition. With stroke patients, cognitive deficits can look like a lack of attention or inattention. And this can be globally or one-sided, which overlaps with neglect and visual perceptual deficits, which we will talk about next. Stroke patients can be disoriented or confused. They may have impaired memory or may be unable to sequence simple tasks, such as combing their hair or putting on their socks. Patients may present with impaired insight, judgment, and problem-solving skills, and this can present as impulsivity, a lack of awareness of safety, their limitations, and their capabilities post-stroke. So what is visual perception? Visual perception, like cognition, is huge and complex, but this is a very simplified definition. Visual perception is the brain's ability to interpret, understand, and define the information that our visual system takes in. So deficits in visual perception can include spatial deficits, where patients have difficulty orienting things in space. For example, difficulty orienting themselves in relation to chairs or doorways, or difficulty orienting objects in relation to each other or themselves. Patients can have environmental neglect and or personal body neglect. So with neglect, patients may not attend to objects or people on their left side, or they may use their left arm and leg during functional tasks normally. Patients may have personal neglect where they don't attend to their left arm, forgetting to put this on the walker or a grab bar, and may not use this arm or hand in functional tasks. This is also related to apraxia, with apraxia being motor planning deficits during tasks. Patients can also have figure ground discrimination impairments, where there's difficulty perceiving objects in complex or cluttered space. For example, finding things in a drawer, on a counter, or in a closet. Visual loss is the actual loss or impairment of aspects of the visual field after stroke, whereas neglect is more about the interpretation, awareness, and attention of visual information, and really has nothing to do with visual field loss. I know that you've heard about the areas of the brain and the different parts and sides of the brain earlier this morning, but I'm going to just very quickly highlight the lobes and the hemispheres of the brain related specifically to areas of cognitive and visual perceptual impairment after stroke. So this here is an image of the brain and the four cortical lobes: the occipital, frontal, temporal, and parietal lobes. So the occipital lobe is the primary visual cortex, and this is responsible for visual reception, recognition, and field loss. The frontal lobe is responsible for organization, attention, problem solving, judgment, executive functioning, and short-term memory. The temporal lobe combines sensory information associated with the recognition of identification of people, places, and things. And the parietal lobe is responsible for visual spatial function, such as locating objects, drawing objects, and is also related to neglect. So here are some typical visual, perceptual, and cognitive impairments based on left versus right hemisphere damage. Damage to the left hemisphere of the brain may result in aphasia, bilateral motor apraxia, diminished organization and sequencing, loss of right-sided motor control and right-sided sensation, and right visual field deficits. Damage to the right hemisphere of the brain may result in attention deficits, unilateral spatial and/or body neglect, visual spatial impairments, left-sided motor apraxia, loss of left-sided motor control and left-sided sensation, diminished insight, and left visual field deficits. So here is a short video of stroke survivors talking about their experiences and the complexities between neglect and visual field loss.
Yeah, because Alan's middle often isn't it the middle.
The middle is the right.
I used to always eat on my right side, but not on the left side. Just leave that.
Give her a dinner plate and she'd only eat the vegetables and leave the meat, which is disappointing because I was the cook.
So if you start a picture, it can not fit in the paper if it gets over to the left, because it hasn't left enough room.
Spatial neglect is a syndrome, that is signs and symptoms that patients most frequently have after stroke, but sometimes in forms of Alzheimer's disease, where they ignore one side of space. So people, objects and sounds on one side tend to get ignored, and the patients who have it tend to be drawn to the other side. And this can extend to things like the food on the plate in front of them. They'll only eat food on this side and then say they're finished. It may extend to parts of their own body, so when trying to shave, they may only shave this side of the face and miss out this side, put makeup on.
So you can only see from across there?
Yeah, from there to there. That's my vision.
So what's going on in the other half?
Nothing.
There's nothing at all?
Because often I've come up from this side to give you something.
Anybody can creep up my left, I wouldn't know they were there.
He doesn't see anything.
I can't sense them.
So if you just look at me and just point at the finger that moves, okay? Or say both if both. Tell me which finger moves.
First one.
Yeah.
That one.
Okay.
Yeah.
Look at me.
That one.
Okay. Look at me.
That one. That one. That one. That one. That one.
Great. That's fine. They tend not to describe the condition, to be honest. One of the most intriguing things about it is that this sort of loss of attention for one side of space doesn't leave a great gaping hole, and that's why it's very useful to contrast it when someone's got what's called a hemianopia, which is a primary sensory deficit. They can't see that side of things, and they know they can't see it, so they're constantly moving their heads like that, whereas patients with neglect are unaware of their deficit, that they're not even aware that they're missing something, because their sort of imagination of space has gone on that side too.
Does he have a name?
I haven't thought of one.
I can stand right next to you, can't I? You can't sense I'm there.
No, you can't.
If you told her to look, she'd actually look around that way, like that, right round on the right hand side, and then come back to central. She wouldn't actually think about coming and looking round to the left as well.
People often say, why don't you just tell them to look to the left, and relatives can be very frustrated about this too. And I think you've got to be aware that the process of attention and these higher visual areas are involved in the representation of space rather than just seeing things where they are. See the lines there?
Split them in the middle.
Yeah, that's one end, that's the other end. Show me where the middle is. Mark the middle for me.
I was only looking at a line from there to there. It's in the middle of my line, not the middle of your line.
So the first time I saw you, that's where you were marking the centre of the line as well. Patients realise something's wrong when things are pointed out to them over and over and over again. So in a way, I think for them it's slightly abstract, that they know that there's some problem on the left-hand side, and they're not aware of that problem, but they know everybody's telling them they have to do something more on the left. And so they use strategies and things like that to try and overcome the problem without really being able to appreciate it in its fullness.
I remember getting those word search books, and I remember it was only one side was always ever filled in. Yeah, and then slowly she got better and better at it, because I used to say to her, Colby, you know, I'm not getting value for money here, you're only doing half the page. Yeah, so slowly she learned that, yeah, do the left side first and then come back to the right.
Some people have it soon after their stroke, and it gets better within a few weeks. And then another group of people have it long term and learn strategies to overcome it. So if you probe deeply, they still have problems with attention. Even that bias may go away, but they still have deep problems when trying to find things, and then they also tend not to remember where things are after they've looked at them. They have poor working memory for space as well. So a lot of these deficits don't recover, although people can use strategies to overcome them.
Give that the police if they find you. That's good.
So just to kind of debrief this video, with visual field loss like hemianopsia, which is blindness over half of the field of vision, the important thing to note is that patients are aware of their vision loss, and they will compensate for it by moving their head. In contrast, patients with spatial inattention or neglect are unaware of this loss of space. And it's important to note that this loss of attention on one side isn't black or a gaping hole. It doesn't appear that way at all. They're not aware of it. So it can get very tricky when stroke patients have both neglect and visual field loss. And for patients with inattention or neglect, they may never recover this loss, but have to learn to compensate and adapt with strategies. So nurses are the gatekeepers of OT assessment. So in lots of instances, patients with cognitive and visual perceptual deficits are not identified by physicians and nurses and are never seen by an OT in acute care. Because cognitive and visual perceptual deficits are invisible deficits, these can be missed quite easily in comparison to, for example, a flaccid arm or a facial droop. According to best practice stroke guidelines, all patients admitted to hospital due to a stroke should be seen by rehab professionals, including occupational therapists, within 48 hours of admission. A lot of the time, nurses will have to ask the physician to put in an OT order. A common tool for initial screening by nurses on acute stroke units is the NIHSS. And I know you've all learned about this earlier today, so I'll just go through this pretty quickly. The NIHSS is the National Institutes of Health Stroke Scale. You must be trained and certified to administer this. It's a 15-item impairment scale. It's used to evaluate a neurological outcome and degree of recovery for patients with stroke, and it's used in planning post-acute care disposition or discharge. The scale assesses a variety of areas, but does include visual fields, coordination, language, speech, and hemi-inattention or neglect. The NIHSS has established reliability and validity for use in prospective clinical research and predictive validity for long-term stroke outcome. So what does the scores mean? The higher the score, the more severe the impairments post-stroke, with 25 or higher, very severe, between 5 and 14, mild to moderate impairment, and under 5, mild impairment. In general, a score of 6 or higher warrants inpatient rehabilitation, and 80% of patients are discharged home from acute care if they have an NIHSS score of 5 or less. However, it is important to note that there have been countless instances where OTs assess a patient with a very low NIHSS score and identify more pronounced deficits where inpatient rehab is recommended. So this is usually because these deficits can be really hard to notice if you don't know what to look for. And the best way to see these is not always through a standardized assessment, but through functional tasks. So formally, it is very important to use a standardized assessment like the NIHSS as an initial screening tool. However, looking for deficits through function can be a very powerful tool. Here are some examples to pay attention to in acute care. However, please note that these deficits here can be much more subtle. So during ambulation, patients may collide into items or objects on one side. They may appear to be ignoring you when you're standing on one side of their bed. Meal trays are important to pay attention to, as patients may leave one side of the tray untouched. One thing that I try to do with patients, if appropriate to do so, would be to see where the doorknob is on the door to the bathroom, for example, and see if they can find this themselves when they're walking to the bathroom. When placing medications on the bedside table, patients may ignore these if it's placed on one side of the table. Patients during grooming tasks may brush one side of their teeth, shave or apply makeup to one side of their face, or when getting dressed, may dress one side of their body. A patient in a wheelchair may propel the wheelchair with one side of their body only. So let's take the example of brushing your teeth. So this may seem like a simple task to you and me, but when a stroke patient has a cognitive and/or a visual perceptual deficit, this task can be very challenging in a variety of ways. And it can be very hard to determine why the patient is having difficulties and how to provide treatment or intervention based on these deficits. So when an occupational therapist is assessing ADLs, such as a task like brushing your teeth, with a patient, we're thinking about all of these things on this slide. Everything from spatial relations and positioning of the toothbrush and the paste in relation to the faucet and the mouth, neglect related to finding the items in the faucet. Questions we're asking is the patient brushing the affected side of their mouth? Are they having difficulty motor planning? Are they taking the toothpaste tube and trying to brush their teeth with that instead? Are they able to sequence this task? Are they getting distracted? Can they see the white toothpaste tube on the white sink? Can they initiate the task? Are they perseverating or getting stuck, repeating the same thing over and over again? So look at all the things involved with brushing your teeth. As you can see, a simple task like brushing your teeth can tell you a lot about what is going on with a patient's brain after stroke. But you have to know what to pay attention to, and you have to let people try to do things themselves and kind of squash the urge to jump in and help right away. As a nurse, this level of complex assessment on this slide is certainly not realistic or expected, and that's where occupational therapy comes in. So please, please, please advocate for a referral to OT. Best practice guidelines state that all acute stroke patients need allied health and OT assessment within 48 hours of admission to hospital. Therapy should begin as soon as possible once medically appropriate. All stroke patients should be screened for visual perceptual deficits and cognitive deficits because these can go easily unnoticed. You can find the Canadian Stroke Best Practice Guidelines at www.strokebestpractices.ca. So the occupational therapy role. OTs assess deficits and provide specific intervention and treatment based on a variety of assessments. It is important that these assessments are both standardized assessments and functional assessments. So for example, using the task of brushing your teeth can tell you a lot about what is going on with a patient's brain, but you can also have lots of other assessments going on as well. So in addition, these assessments on acute care units can be clock drawings or copy tasks. Here you can see a patient with left inattention or neglect has completed this worksheet on this slide. The left side of the clock, the house, and the cat are missing. Furthermore, on acute care, you will see occupational therapists completing standardized cognitive screens, such as the Mini Mental Status Exam, or the MMSE, or the Montreal Cognitive Assessment, the MOCA for short. Higher level IADL assessments, such as medication management assessments and simple kitchen assessments, are also used on acute care. Scanning sheets, such as this line cancellation task on this slide, is another way to screen for visual perceptual deficits, with this patient experiencing left inattention or neglect and missing the lines on the left side of the page. So how can you help? I'd start the next 4 slides because these are the most important slides of the presentation. So if you've been sleeping until now, remember these strategies for how you can help as a nurse on the acute care unit. So firstly, and most importantly, advocate for an OT referral for all of your stroke patients. Another simple thing that you can do is to make sure that your patients have their glasses and their hearing aids on. When giving instructions, less is more, and really try to slow down. You can put patients' belongings back where you found them. Avoid cluttered surfaces and spaces, such as the picture on this slide. And try to keep lights on and window blinds open during the day. A few more strategies that could be helpful is to keep the whiteboard information updated. Provide access to a clock. Look for unilateral differences, but watch for these during bilateral tasks, because this is usually when you'll see them. Think about placement of food, medications, and grooming items. And anchors or reference points can be used with patients with neglect. So on this slide here, they're using an anchor, and it's just a piece of green tape on the left side of someone's meal tray. And it's just cueing them to look to the left when they're eating their meal. Another good thing that you can do is to get patients up and out of bed when able or appropriate. You can really learn so much from early ambulation. Encourage patients with neglect to scan towards their affected side. The lighthouse strategy is a simple way to encourage this scanning. You ask the stroke patient to imagine their eyes as beams of light sweeping from side to side like a lighthouse, and remind them to use the lighthouse strategy during daily activities. You can provide sensory input to the affected arm or leg, and always remember that environmental setup is key. So for example, don't put a call bell on a patient's neglected side. One simple thing that you can try to do is putting a patient in front of a mirror for ADLs. And this can be a really good strategy. So if you're able to set them up at the sink in front of a mirror, please do it. Ensure a patient's affected arm is not caught in a wheelchair wheel, a bed rail, or getting bumped on a door frame, etc. When to cue and not cue the patient depends on if you're trying to identify deficits or difficulties, or now that you are aware of these, if you're trying to assist the patient when completing a task. Hand-over-hand assistance is way more beneficial with neuro recovery than just doing a task for a patient. So always try to encourage that or use hand-over-hand assistance. And ultimately, it's best if you let the OT provide education to the patient and family about these deficits, as patients and family will sometimes put a lot of weight into the information that they're provided with on acute care. And we want to make sure that this information is provided in the best possible way. So please ask the OT to come and provide this education, because this is our area of expertise and we would love to do it. If you want to learn more, there are a ton of references at the end of this presentation, but this is where I would suggest that you start. This is the Core Health Ontario website, specifically the nursing core competencies, which is free access for nurses to learn about cognitive and visual perceptual changes following stroke. And it's based on evidence-based stroke care. One of the suggested learning resources in the core competencies is the Southwestern Ontario Stroke Network Acute Stroke Unit orientation module. And this is on cognition, perception, and behavior. And you can access this at this PDF link right here. So in summary, know what you can look for to identify cognitive and visual perceptual deficits post-stroke. Advocate for a referral for OT for all acute care stroke patients. Let the occupational therapist provide education to the patient and the family. And try to make it a habit to use and integrate strategies to help patients with cognitive and visual perceptual deficits on acute care. And continue to seek out education and learning opportunities. Here are some of the references if anyone is interested. Thank you everybody for attending this presentation. I think we're going to move into questions now. I've also provided my name and email address, so please feel free to reach out if you have any other questions later. Thank you again.
Thanks, Kassi. That's a great talk. Cognition and visual perception are so complicated that we're really pleased you're able to share some of your insights with us today on those topics. We're going to now take a few minutes for questions. So I remind people to please type your questions into the Ask a Question box and I will read them out. Also to remind you to click on the evaluation survey for this session. Again, you can find it on the right side of your screen. So first question to start off, should you always position yourself on the patient's good side versus the neglected side when you're working with them?
Yeah, so that's a really good question. I guess the short answer would be it depends. It really depends on the patient. And it would be really good to talk to the OT that is working with the patient to kind of see what they recommend. But typically, if a patient if their inattention or their neglect is a little bit less severe, it might be a really good idea to stand actually on the side that is not their good side, kind of force them to look at you and scan over at you and interact with you on that side. And it might be something that is kind of like therapy that you can build into their daily activities, because we can only see them for so long a day. However, there are patients that have really, really profound neglect and really profound inattention, and they, that might be too soon. And to actually provide really good care and to allow them to have a really good, experience and like a little bit better quality of life, and just after their stroke, you might have to be on their good side, just because they will not interact with you or really see you at all if you're on the side that they can't really attend to in that moment. So I would just check in with the OT, and they would probably love for you to ask them that, and then they can kind of give you direction.
Right. Just depending on which patient you're working with, eh?
Yeah.
Could be different, right?
Definitely, yeah.
Okay, good. So next question, what type of cognitive assessment do you usually do when you, as an OT on an acute care unit?
Yeah. So that's a really good question, because I think acute care, we are really limited sometimes, and it's really fast paced, and it has to be something that can kind of be quick and tell us a lot of information in very little time. So probably the one that you're going to see the most is going to be the MOCA, the Montreal Cognitive Assessment. So that's probably like the OT bread and butter that you're going to see a lot on the acute care units. You're probably going to see some clock drawings for sure, potentially like a mini mental exam. You might see a lot of kind of like, they're from like a behavioral and attention test, but it's kind of like some scanning worksheets that I had talked about and kind of put up on some of the slides. So those are really good assessments that can happen really quickly. That we will often bring to bedside, and even if people can't typically even get out of bed, it's a good assessment that we can do just sitting up in the bed, and kind of quick and dirty figure out what's going on with the patient. So lots of different scanning worksheets are something you're probably going to see. And then, acute care too allows for hopefully some functional cognitive assessments too. So maybe less of the standardized type, but OTs will often bring in like sample medication assessments and try to see if somebody can manage their own medications. Lots of times if people are able to move out of their room, we will take them to like just like the mini kitchen on the unit, and we'll try some really simple kitchen, like just tea and toast or microwave meals or stuff like that. So you'll probably see us with patients in there as well if we can, and it's really surprising and quite valuable to see what some of those functional assessments can show you in combination with some of the paper pencil standardized ones as well.
Right. Okay, good to know. And you talked about kitchen and functional things. So let me ask you about driving, which everybody seems to want to know about, and how cognition can affect your ability to return to driving, or some of the other tasks you mentioned, like cooking or taking care of your own medications, that sort of thing.
Yeah. So driving's a really big one, but it is one that I think is really important to start thinking about early on, even on acute care, especially with patients that might not to potentially go to rehab, like some of the stroke patients that are a little bit more mild might actually go home from acute care. And driving is one thing that's really, really hard and very large topic to kind of cover, but typically a lot of these cognitive assessments can be a starting point to try to think about driving, and then it's typically up to the physician to make a report to MPO. I know at Sioux Area Hospital, it's usually a 30-day suspension of a license is kind of like your typical, anytime someone's had a stroke, the doctor will typically say not to return to driving for a month. And then lots of times it's kind of like up to us to kind of determine what type of follow-up they might need. So that might be skipping the inpatient rehab, but going to outpatient, and maybe outpatient, the neuro OT in the outpatient clinic driving might be the big goal that someone might want to get back to. And in that setting, it can, I mean, it's really large to kind of determine driving, and cognition is one piece, but there's also, you know, reaction time and physical deficits, and there's all these other pieces that come together. So it's definitely a high risk activity, just like cooking or managing medications or even managing money. You know, if these things are really hard and difficult for patients, it can be big consequences. So that's typically where the safety piece comes in. But it is important to think about driving as soon as acute care, and typically nurses can tell patients to ask their OT and talk to the doctor about that. It is a good idea.
Right, great. Yeah, excellent. Okay, I think that's all the questions we have for today. So Kassi, thanks again. We really appreciate you speaking to us today and sharing some knowledge. And I hope there's things people can bring right back to the bedside tomorrow and start utilizing in practice. Thanks again for sharing your knowledge with us.
Thank you very much, Sue.